Are we good to go?
Yes. Good morning, Vikas.
Good morning, Sophia.
Recording in progress.
How are you?
Very good, very good. Sunday morning, you've got still people in the hall, which is brilliant.
Yeah. Okay, thank you very much. Thank you for your commitment. Thanks again for being with us for all this meeting. It was a little bit difficult for you to be with us for 3 times, and 2 symposium and 1 conference. Thanks again. Thanks, my friend, for this commitment. And we will start our symposium with joint with ISACOS. And we will start with Margaret, waiting for John to be connected. And we will start with Margaret with wrist arthroscopy, and then we will go on and we will moderate with you this symposium. Omar Bat is with us in the room, and we will start with Margaret.
Thanks, Sufyan. So we've got hand-picked speakers from around the world for this ISACOS Advances in Arthroscopy Symposium. Some of the talks are already recorded, so they'll be there, and some of the talks we'll do live from here. Margaret, you want to share your screen, or you've got a recorded talk?
I've got a recorded talk that I've sent to them. Have they got it? Have you got the recorded talk? Because
Yeah, they're starting. Perfect.
okay, great.
Good morning. Thank you for the Organization Committee of Tunisian Society to invite me to talk about advances in wrist arthroscopy. So why do we talk about wrist arthroscopy? Because it is important in the management of distal radius fracture in terms of the diagnosis of ligamentous injuries as well as the management of them. Last but not least, it can allow for limited fusion. But today, I'm mainly going to talk about the management of distal radius fractures. So why do we talk about it? It is because it is common. It is common in the osteoporotic patients as well as in young patients with high energy trauma. Previously, we usually talk about open reduction and internal fixations versus cast immobilization in distal radius fracture management. However, because nowadays people tends to want to have early mobilizations, and we also have a theoretical advantage of having anatomical reduction, which may decrease the chance of any degenerative changes. Open reduction internal fixations seems to be the way to go now. So, in wrist arthroscopy, does it have a role in the fracture management? Well, it does. It can assist in the intra-articular fracture reduction and fixation, as well as the cartilage status assessment, as well as the soft tissue status assessment. That includes the TFCC, the scapulonate, and the lunotriquetral ligaments. So let's talk about arthroscopic assisted in distal radius fracture reduction. It provides a superior visualization of the articular surface of the fracture, so that if we can't see it clearly on our normal approach, and we may sometimes use arthrotomy. Now this reduces the mobility associated with the arthrotomy procedures. So how do we actually do it? We do the normal close reduction and then we put a plaster on. Before we do a CT scan to assess the fracture configurations. Then we use a normal volar approach, and then we do the initial reductions of the distal radius. We do the fracture manipulation, and we try to restore the radial height, the radial inclination, and the volar tilt. We then put K-wise to fix the articular fragments. So this is how it's being done. Then we use arthroscopy to assess the initial reductions and the position of the plate. We try our best to restore the extra-articular alignments as much as possible. Then we place the wrist in the traction tower. We use dry arthroscopy, and we only use water irrigation at times if needed to irrigate the blood clots. We use shaver for debridement before we see the fractures clearly. We use 3-4 portals and 6-hour portals of the wrist arthroscopy to assess the fractures as well as to do further manipulations. So this is how the view is, and in this case you can see the fracture is not completely reduced. So what happened? we pull out the KYs, we try to manipulate further, and then we have a good reductions, and then we put the KY in, and then subsequently leave the school. There's a lot of advocates on arthroscopic assisted in fracture reductions, yet there are rebuttals who said that there is no added benefit. So what are the literature results? Well, you can see that in the short to medium term result, there is some study that said that you have a slightly better in range of movement, grip strength, and the functional score. But not all of them said the same thing, and even radiological, some said that there's not much difference. So I suppose that depends sometimes on experience as well. How about soft tissue injuries? Well, in soft tissue injuries in distal radius fracture, the most common that we can find is TFCC, scapholunate, and nototriquetral ligaments. So what are the incidents? If you look at these studies, we find that the TFCC tear can be very high, with up to 90%. Yet, the more importantly, do we need to treat them? Well, this is a famous Lindau study that shows that even though there is a high incidence of TFCC tear, at 1 year's follow-up, not everyone have instability, and only 13 are asymptomatic. If you follow them up in 13 to 15 years, even though that they still have some kind of instability, only 1 is symptomatic enough to undergo TFCC reattachment. Yet nowadays, we do a lot of open reduction and internal fixation. So there are advocates that say that we should do the TFCC repair at the same time. And these studies show that they have good results. So in our center, we believe that anatomic reduction and stable plate fixation can achieve a good osteoarticular congruence of the DRUJ. So TFCC may not need to be repaired and they still will heal, and so the patients will not have any symptoms afterwards. We tried to confirm this postulation, and we studied the TFCC status after the fracture is healed. And we find that, interestingly, not everyone will heal, but not everyone will have symptoms even though that the TFCC remained teared. Now we extended our study. We have 88 patients, and most of them are AO type C fractures. 43 have ulnar stylo fracture, of which half of them have non-union. 48 have some kind of ulnar wrist pain, and 55 have DRUJ instability. Yes, interestingly, quite a number of them still retained to have TFCC tear, and the partial healing is only 14 out of 74. More interestingly, we find that the more complex the fracture is, the chance of having a TFCC tear is high. The correlation is that ulnar wrist pain is correlated with ulnar stylo fracture. Ulnar wrist pain is correlated with DRUJ instability. But there's no correlation of ulnar wrist pain or instability with TFCC tear. There's no correlation of DRUJ instability and complete TFCC tear. There's no correlation of ulnar stylo fracture and TFCC tear. What if we repair them only later when the fracture is healed and the patient is symptomatic, which we did? Well, pre-op, we find that the quick dash score is slightly higher in the TFCC tear group, but the other range of movement, the pain, and the grip are the same. So what if we repair them? Well, we can see that there's improvement at 12 months follow-up. Interestingly, even the TFCC group or the groups that we did not repair because the patients are asymptomatic, they all improve in terms of pain score, range of movement, power, and dash score. And this may be because that we give them a complementary course of physiotherapy and occupational therapy. So anyway, this is the graph that's showing that the improvement of the pain score, the range of movement, and the grip strength. So our study correlates with the previous study that TFCC is common in distal radius fracture, but not all of them are symptomatic. Some of them do heal after open reduction and internal fixation, and improvement is noted even after delay repaired. So our recommendation is that we repair only when symptomatic. Yet, if you don't repair them, in the SL group especially, you can see that there's no difference at 1 year or even at 13 years follow-up. Our results also confirm that there's high incidence of SL and LT tear, but all of them are asymptomatic after the fracture healed. At 1 year, if we ignore them, there's no radiological progression and there's asymptomatic. So our recommendation is do not need to repair them or reconstruct them until the patients are symptomatic. So to conclude, advances in wrist arthroscopy provides a very good role in distal radius fracture management. It is beneficial in a selective group of patients requiring intra-articular reductions. It can provide a good diagnosis of soft tissue injuries, but not all need to be tackled at the same time, and delayed repair can result in good outcome. So thank you once again for inviting me, and thank you for listening.
Special thanks to Margaret, because Margaret was supposed to be in Tunis in person, but for a confinement restriction, she couldn't make it. Then thank you very much, Margaret, and we'll see if there are questions within the floor. Are there questions within the floor? Thanks again for this very interesting study and to explain the importance of arthroscopy, but I think this is a technique which is more time consuming compared to the others, definitely. You need more equipment and stuff that you need, and time and to control all these patients, but we are very surprised with your results, mainly regarding the place of repairing the TFCC and how to deal with distal radial instability. Thank you very much, Margaret.
Thank you. Thank you for having me.
See you next in Tunis.
Sofian, could I ask Margaret one question, if I may?
Definitely, yes.
Margaret, if somebody in Tunisia wants to start off this procedure and is interested, what's your recommendation for them, a young trainee out there?
I think, yes, this is a very good question. I think everybody said that, oh, it takes a lot of time, but actually you need, once you get to know it and once your operation theater staff knows how to set it up, it actually doesn't really take a lot longer. So I would suggest the young trainee to go to a cadaveric workshop to actually learn about it and actually build up cases. So I think we start up with some simple cases, not start up with a distal radius because there's a lot of blood, there's a lot of swelling. And so we started off with young patients with wrist pain and just to get the diagnosis. Even if you want to do open, try arthroscopy first and then switch to open in the first few cases. And then when you're more comfortable, then do the open. Then do the arthroscopy interventions for everything.
Brilliant. Thank you very much, Margaret. Could we now go on to Professor Yon's talk from Korea? That should be a recorded talk available. So if you could kindly play that on shoulder arthroscopy, that'll be great. Thank you.
C'est préenregistré, hein? John O. I think John didn't send his conference, and he's not connected. Then let's go for the next speaker.
Professor Badong, since you're here, we can play Professor Badong's talk and definitely know that he sent it.
Yes. Yes, Dr. Verdonk sent his conference. Yes,
I did.
He sent his 2 conferences. He will have another conference after the symposium, and we thank him very much to participate with these 2 conferences.
This is going to be a perfect hybrid one. I can see Umair sitting there, so he'll probably present live from there.
Dr. Verdonk.
Hello to
Dr.
everyone.
Verdonk.
Good morning, Tunis. It is a pleasure to join. Apologies for not being able to be present at your meeting and the wonderful location. And I will join and discuss maybe some newer things and principles that we try to respect when we look at meniscal replacement and its role and results. This is my disclosure. And the two messages I want to bring to you that are the most important is on the degenerative meniscus, that we really in middle age should be very cautious and look for arthritis and then treat the arthritis and not the meniscus in those particular cases as with the middle-aged individuals. And in traumatic tears, as you may imagine, really I would push the indications for repair. And as we obtain good results with meniscal repair, we should take the risk of failure and do more repairs eventually to go back in again if required. So these are the SCA meniscal consensus on degenerative lesions that you may have read and looked at in the CESTA journals. And the idea is not to be too aggressive towards degenerative menisci. When you are confronted with a non-locked, painful knee in a more than 35-year-old individual with a clinical history that you may suspect a degenerative meniscal lesion, then take X-rays, not an MRI, but X-rays, standing X-rays. Think about the Schuss view, AP and lateral standing. And move on to a non-operative treatment, at least for the 3 months since the onset of the symptoms, except if you have considerable mechanical symptoms. And then you may have treatment success, and of course this is the end of the issue. If you are in treatment failure, then an MRI might be indicated, unless it is already done. And if there is no indications or evidence for OA on X-ray and an MRI, then you may move on to an arthroscopic partial meniscectomy and eventually help these patients. If you have evidence of OA, then you treat the OA. In the traumatic tears, well, we know these tear patterns, you know them very well because you treat these. And we only do, like overall in the orthopedic world, like 10% of repairs, which is too few. And it may be that you look at a gap between what we call daily practice and science on the subject. Well, repair versus partial meniscectomy, of course, leads to less OA. There is higher return to sports, and there is a higher Lesson score. This has been confirmed by several studies. Our mantra, or at least the SCA mantra, is that we should take the risk of failure when you're confronted with meniscal rupture that is fresh. Now, these are statements, and I'm sure you want to agree with this. We should save the meniscus, invest in the future of the knee health, and meniscal repair or partial meniscectomy will evolve towards asymptomatic, which we really hope so, or symptomatic. And then we have meniscal scaffolds to help, and meniscal allografts that have their indications. And I want to digress on this a little bit with you. The scaffolds that are available is the CMI, and that is a porous collagen structure. And there is the ActiFit, which is a biocompatible aliphatic polyurethane implant. One is stronger, the other one is more natural. And if you look at clinical publications on the ActiFit, you see that several are available. with quite a big journal impact factor when you see whether they've been published. You see that the general age of these individuals are younger. It's not the ones that we discussed with the degenerative issues. Then it's more medial than it is lateral. And that you find in literature, and I think that's important, 55 of these implants have been used together with concomitant procedures. Concomitant procedures that are ACL repair or alignment procedures. You see, most of these patients are male. Lots of patients have been enrolled. And we now have like follow-ups up to 10 years. And this is a very interesting study recently published in arthroscopy by Zafani and his group in Bologna. And you see that when you compare both, a comparison between the ActiveFit and CMI at 10 years, I think is very important. There is a similar positive clinical results. They didn't really look at illustrations or imaging, but the clinical results is very important, is the same, and it's like 80% of implant survival at 10 years. I think that is a major information. There was no imaging in this investigation. You know how difficult it is to get these images at 10 years in the follow-up. But remember, there is no correlation between images and clinical results. So what have we learned over these 10 years? That we are confronted with good healers, young and active patients. This is a prerogative, very important. It should be a stable knee and a well-aligned knee. No grade 4 or advanced kissing lesions. And of course, no joint deformities or femoral squaring. And on the meniscus profile, it should be symptomatic, and I think that's very important for the indication, meniscus insufficiency after failed partial meniscectomy or failed meniscal repair, with a segmental mid-substance tissue loss and regarding stability, intact rim and horns of the meniscus that you want to implant. But then, when the meniscus is gone, then we need to replace the meniscus with allografts. And here, there is almost 40 years of follow-up available in literature. And this is a slide from Tim Spalding. And look here at the middle of the slide, the main indication, and you should do it the earlier the better, is the post-meniscectomy syndrome, meaning that the meniscus has been resected fully. Think about the discoid menisci. Of course, you may think about prophylaxis and replace before any changes occur, but that's not yet the rule. And you may attend also salvage cases. Salvage cases or instability cases where both the menisci help to stabilize the knee joint and protect the cartilage. And this really has long-term data. You see the illustrations here from the US and Canada, from UK, from Europe, and our own results on the matter that have been published and increasingly suggest that this has a future in the long-term treatment of the knee health. But the prognosticators for survival in these investigations are that there is no difference between medials and laterals. We now kind of know that. No really difference between male and female. But the cartilage wear has a negative effect. So the younger you have the individual, the better it is. And the age, the older the patient is or are, the more negative effect. So think about that when you're confronted with the young individuals where the lateral meniscus is being removed. Now we may have new research that may illustrate this. And investigations suggest that cellular injection strategies may increase the cell number in the implant because we use them as fresh frozen. Some cells may survive, but if you add some cells, it suggests that it's functioning better than just pure dead implants. And what about the allografts and the normal knees? There's been a comparison of demographics and sizes of donor knees, normal donor knees, where we get our allografts from, and the recipient knees. And what do we see? There is a difference in the meniscus surface and also in the meniscal sizes. So one is not like the other. So it appears that the ones that we implant our allografts in are different from what you and I should call normal knees. And the patients that are in need of a meniscal allograft, now we see that post-meniscectomy knees and ACL instability, they have really a significantly smaller medial compartment. So probably some of these knees are bound to have issues in later life. And this is being investigated in a computer model which may predict the outcome of meniscectomy and thus lead to meniscal surgery and meniscal allografting. They compared a meniscectomy patient in a low-risk group and a high-risk group. And post-meniscectomy patients have a specific morphology. They are overall small, they have a small mediofemoral condyle, and they have a bigger notch. So less surface for weight bearing, leading to degeneration. Ladies and gentlemen, if we conclude on meniscal allografts, I think we can rely on the procedure. We have significant long-term clinical improvement. It's a successful bridging procedure towards total knee arthroplasty in a number of patients. You can return to low-impact sports, but in Europe, we have limited availability as we compare that with the possibilities in the United States. So as a conclusion, on the menisci, repair whenever possible, replace partially when a chronic removal has been done, and replace with allografts when confronted with a painful knee after full resection. So thank you very much for your kind attention, and I wish you further success in your meeting. Thank you.
رجع فيكس.
Yeah, I'll share my screen whilst you ask Professor questions. That's fine. Any questions from the floor for Professor Verdonk?
Yes, it was a very good presentation, Dr. Verdonk, but in Tunisia, the problem that we have not grafts, allografts, we have not scaffolds, but we have to find a solution of this type of patient that had post-meniscectomy syndrome. And I would ask you, what do you think about meniscal reconstruction using SOMITI or peroneus longus? Do you have any experience with that?
25 years ago, I've done a very few limited use of quadriceps tendon, as it was described by Dieter Kohn in the former times, but that has not been a success. I know from Carl Eriksson from Sweden, who has just started to use a tendon to replace the meniscus, and probably it could add to a solution when you're not available with these partial replacement or with a full allograft. But I think a tendon, as according to Dieter Kohn's investigations, a tendon material will never change to a collagen material. So you may add to have a solution using these tendons very in a very timely basis, and probably I would suggest for the media compartment to, and that you have for sure a large experience on, this correcting the axial alignment, even though it may be minimal. This may in the media compartment bring a solution, and I would suggest to do that. And the allografts nowadays, we do more laterals than we do medials, because we have so good success, as you may expect, with corrective osteotomies, even in minimal malalignment. But the issue is more in the lateral compartment, where the allografts are more necessitated, because you don't have any good standard solution doing a varus osteotomy in case of a valgus knee. So the issue is more in the lateral compartment. There, we need more grafts, and the system in Europe is not really efficient, and therefore ESCA is really pushing to the science that indeed also economically the allografts are a plus. We know they are when you use osteochondral allografts. This has been proven. It's documented also economically, of course, clinically, but it has not been able to show that right away with meniscal allografts, even though you may be sure that the clinical evidence is present, maybe not the economic presence. I hope this is a type of an answer. The medial compartment is relatively easy, even though it may not be perfect with osteotomies alone, but the lateral compartment is much more of an issue.
Okay, thank you very much. We go for Vika's conference.
Thank you very much for the kind invitation. Thanks, Prof, as well for being there Sunday morning. So rather than give you technicalities, I think what I thought I'll do in this 10 minutes is give you 10 lessons that I've learned over the last 15 years with the arthroscopic surgery of the hip. To bring you greetings from our biomedical campus in Cambridge, and these are my disclosures. So for us, really, the history for hip arthroscopy began with this man. He's my mentor, Ricky Villa, who did the first hip arthroscopy in the UK in the 80s. And since then, the number of hip arthroscopies being performed in the UK has grown significantly. If you look at this graph, over the last 10 years, 2002 to 2012, the procedure grew by 727%. And the projected growth over the next decade until 2023 is almost 1400%. There hasn't been any procedure in the history of orthopedics that has actually been charted to grow so much. This is only in the UK, but in the US, it's much more. So the first lesson is that we need to have a comprehensive clinical examination, because it's not the standard hip that you're examining. There are a number of causes of hip pain. You've got intracapsular problems, you've got extracapsular problems, and you've got extracapsular non-musculoskeletal problems, which will all present with hip and groin pain. And these number of causes actually keep increasing by the month. So the simplest way of thinking about it is to divide it into extra-articular, non-musculoskeletal, extra-articular, musculoskeletal, and articular causes of hip pain. So that's the first thing. And a comprehensive clinical examination would consist of thinking of the hip joint in 4 layers, 5 position examination, and 21 steps to hip examination. So it's not the standard aptly look, feel, move anymore. It's a lot more to that. So that's what you need. And that's the first lesson. The second lesson is that we obviously have major advances in clinical investigation as well of these patients. And for us, the 3D CT is the game changer. And I'll tell you why. Obviously, we'll get the standard AP and the cross-table lateral radiographs to look at the anatomy and the morphology. We'll obviously get the MRI scan to look at the acetabular labral tears, if there's any edema in the femoral head, the state of the articular cartilage. But if you look at the 3D CT scan, that clearly shows you the cam morphology, that shows you the coverage of the acetabulum, the pincer morphology. It shows you subspinous impingement on the anterior inferior iliac spine. It shows you any rotational abnormalities of the femur and any version abnormalities of the acetabulum. So everything that you need for correction of that patient, be it an osteotomy or an arthroscopy, a 3D CT scan will give you. So this is really a game changer. It also gives you a clear idea of the posterior joint space. So a lot of patients are not suitable for hip preservation surgery if their posterior joint space is significantly reduced, which may be looking pretty okay on the AP and the cross-table lateral radiographs. And the other thing is, if you've got availability of this, you can send that specific CT scan to this company called Clinical Graphics. And for a few £100, you will actually get pretty much dynamic analysis like this for that particular patient. So you know exactly in which movement through collision analysis the patient is impinging. So the CT scan can be extremely helpful in actually helping you both diagnose and also treat your patients. Again, the CT scan, if you are into complex deformity workup, can actually give you 3D printing algorithms like this, which will allow your surgery much better. So that's the second one. The third one is that the diagnostic hip injection is essential. A lot of these patients are referred to us in 2 or 3 years by the time they actually come to the clinic. So one thing which determines whether the pain is intra or extra-articular in origin is actually injecting the hip joint with some local anesthetic, and we do some steroid as well to ensure that their hip pain goes away before you embark on any intra-articular surgery for them. So that's, again, essential. Point number 4 is that you really need to pick winners. Hip arthroscopy or hip preservation surgery is not for everybody. And there are clear people or patients who would actually not benefit from this. So stratification is essential, and you need to pick your winners, pretty much like any surgery, but more so with this one. So outcomes would be dependent on the patient themselves, the morphology of the hip, because there are certain morphologies you will not be able to correct or help with hip preservation surgery, be it arthroscopy or osteotomy, and obviously your own technical ability. How good an arthroscopist are you? So the first one is age. Definitely the older you are, the lesser the chance of you improving. Females also seem to not improve that much following arthroscopic intervention. The higher the grade of articular cartilage injury, the less the improvement. And high BMI patients also don't improve. We've also learned that if you are beginning to get edema in your femoral head, we've also learned that if you're beginning to get cysts around the femoral head or the acetabulum, then these are the patients who are not going to improve. Reduction in posterior joint space, significant SUFI, all these patients may not improve with arthroscopic intervention, so should not be embarked upon. The CT scan comes in here again, because if you've got a rotational abnormality of the femur of the acetabulum, you're better off doing an osteotomy rather than an arthroscopy, actually, for those patients. Patients who've got mental health issues, patients who've got hyperlaxity, patients who are not going to buy into your 20-week rehabilitation protocol are again patients who will have less favorable outcomes following arthroscopic intervention of the hip. So that's about picking winners. The next point is the surgery is dependent on 2 Ps. And I always tell these to all my fellows and residents. You need accurate positioning of the patient, and you need accurate portal placement. If you get one of these 2 Ps wrong, you're going to struggle throughout the whole procedure. So this is the setup. I do it in the lateral position because I do my hips in the lateral position as well. You've got the leg there. You've got the bolster there, which actually lifts the hip out of the joint. And then you've got the traction device there. And then the image intensifier comes over or under the table, whichever you prefer. The hip is at about 30 degrees of abduction because that's what gets your leverage force. The leg is being pulled in that direction. This bolster is pushing the hip out in that direction, and the resultant vector force is in that direction, which is parallel to the femoral neck, and therefore we do not get femoral neck fractures when we actually do this procedure. You put the patient in a reverse Trendelenburg's position, it becomes much easier to distract that joint. So positioning is key. And then pretty much like the knee, we have got three compartments in the hip. You've got the central compartment there. You've got the peripheral compartment in the front with the peripheral cam lesion. And then you've got the lateral or the extra-articular compartment. So that's how we actually get it. Once we start distracting the hip because of the negative intra-articular pressure, you see that halo effect, and you're distracting the joint by about 10 to 15 millimeters to put a 5.5 or a 4.5 millimeter scope in. The labrum is avoided because you'll fill the joint up with 40 mils of fluid. You can see the silhouette of the labrum, so your needle should not go in there. Your needle needs to go beneath the labrum, and then your procedure is going to be fairly easy. So portal placement is key. In the peripheral compartment, again, we go in front of the hip joint to take the cam lesion out. So we use the Dean's portal, which will be in between the femoral head-neck junction there. And unless and until you see the backflow of fluid, you should not be entering with your wire and then scope, because then you know you are actually in the peripheral compartment of the hip joint. So those are the two P's for access to the hip. When we started off hip arthroscopy, it was still a procedure for the mavericks. And you really need engagement with government policy and influence to actually make this a regular procedure. So we looked at the Cambridge and Peterborough Clinical Commissioning Group, worked with them to actually make guidelines, the British Hip Society, the British Orthopedic Association, and the National Institute of Clinical Excellence. All these four bodies we were engaging with to ensure that we had a robust plan for actually engaging and then getting this procedure on the NHS. So we started off with a simple clinical policies forum. Then we went on to NICE to get the specific document for treating hip impingement with arthroscopic surgery. Chronic hip pain guidelines were produced. And then most importantly, after these guidelines were produced, we also agreed to submit all our data and started the non-arthroplasty hip registry, which was started in
literature.
Got 17,000 procedures recorded on that now. So it's essential that you actually engage with the government and policy if you really want this to fly in your country. You also need research, continuous learning, and graduate training for this. So research output and collaboration have been high, both in terms of publishing papers and also grants, and working with other universities like Ghent to actually look at specific projects and then take them to completion. Major trials like FATE have been done both with Oxford and Cambridge, actually to look at the effect of arthroscopic surgery compared with physiotherapy on patients with FAI, and clearly arthroscopy showing a better outcome in the shorter term. And then books like this also are essential to push the specialty forward. So certainly exciting times ahead as far as hip preservation surgery or hip arthroscopy is concerned, with disease stratification, precision surgery, wet labs and simulator training, huge opportunity for product development, cartilage repair, as Professor Verdonk has shown in his meniscal talk, and then national and international trials. And all of these are being done at a smaller scale and then being amplified with societies like ESCA and ISACOS on a larger scale, especially the national and international trials and cartilage repair aspects of it. We've got a well-developed research program now, and our philosophy is optimizing outcomes. So we've got 5 PhDs looking at the surgical risk factors and the non-surgical risk factors for hip arthroscopy, and focusing specifically on how can we optimize outcomes in these patients. Got a structured training program, which consists of a fellowship in young adult hip surgery, simulation training, an annual cadaveric skills training course, and then mentored independent practice. We've been fortunate to have trainees and visitors from all around the world over the last 15 years learning this procedure and also the cognitive aspects of it. Finally, it's not a single man sport, it is a team sport. You really need all these individuals involved to make a good unit. You need a good radiologist, a pediatric orthopedic surgeon, a young adult arthroplasty surgeon, osteotomy surgeon, the fellows, the physiotherapists, sports physicians, and a good national and international network to get this program off the ground. And it's certainly not for the occasional operator. You cannot be doing one hip arthroplasty, one shoulder arthroplasty, one ACL, and one hip arthroscopy. If you're doing this, then you really need to be committed to it, and you need to be doing loads of these. Because the acquisition of dexterity is a slow process, and it's not without complications, and therefore should not be undertaken by the occasional operator. On that note, I would like to invite you to the International Society for Hip Arthroscopy or Hip Preservation annual meeting in Glasgow, 13th to 15th of October. I'll be chairing the scientific program and would be really welcoming you to this meeting in Glasgow. Thank you very much for your patient listening, and pleasure to be lecturing here, and apologies for not being there in person. Thank you.
Thank you very much, speakers. We will go for Omer.
So I'll be giving a talk on primary ACL repair, Back to the Future. Okay, so I'll just quickly whiz through. I work in a hospital, Karachi, for the last few years, and I also work in the past hospital called Sulis now. It's called Sulis, it was previously called Circle Bath Hospital. How do we move the slide, Sufyan?
On the circle, on the anterior part.
Is this working?
Yes.
Which direction should I push? Okay. Up and down. Thank you. So direction. Thank you very much. So kind of you. So if you look at the historic fact, we will see that even the Greek physician during the Roman Empire was the first to describe the true nature of ACL. So this ligament is something which for many years have been thoroughly investigated and learned by many of our mentors and teachers. We know that over 200,000 ACL injuries happens in USA, and reconstruction is still considered a gold standard. But we also know from the fact that when you do a good quality ACL, it doesn't come without its own complication. There is a risk of revision, almost up to 8%. Infection, coming up to 3%. Unhappy knee, anterior knee pain, quads atrophy, and risk of osteoarthritis. But despite all these facts, we still feel that ACL reconstruction is a gold standard, and we still do them in big numbers. I think this thing doesn't work. Now, if we look at the history, Mayor Robson was the first to perform in 1903 repair of both cruciate ligaments. And Haygrove actually popularized ACL reconstruction during the 1970s. And Palmer popularized open ACL repair, and this became a very common procedure. And during the same time, Fiagan and Curl were the first to note that deterioration of result in midterm follow-up. So the two procedures started together. One was primary ACL repair, one was reconstruction. So what was the reason that reconstruction became very popular and repair was on the back burner? And I'll tell you the reason behind it, which we were able to identify. There was a paradigm shift in early 1990s when several randomized control trials were performed showing superior result of reconstruction. The evolution of primary ACL repair through the prism of modern day understanding is important. Sherman was the first person in 1991 to do subgroup analysis. He wanted to look at what was the reason that repair was not considered gold standard and reconstruction was considered. So he subdivided ACL tear into 4 categories: type 1, 2, 3, and 4. Type 1, proximal tear, less than 30% separation. Type 2, more than 30. type 3 mid-substance tear, and type 4 tibial avulsion. And he looked at the literature that was the cause of the failure. So if you look at this publication from 1984 to 1990, interestingly, majority of the mid-substance tear had a much higher failure rate. 61% satisfaction, 23% satisfaction, higher revision rate, and they identified that the mid-substance tear, when you repair them, the risk of failure was much higher. He also looked at other studies in which the repair was done for the proximal tear. So 1991, study by Kune. Janelin and Ronist in 1989. If you look at the result, if it comes on easily, 75 patients, 42 patients, and 51 patients. So if you look at the first study, the proximal tear, 4 years follow-up, 89% had negative pivot. 42 patient proximal tear, 5 to 7 year follow-up showed 86% satisfaction. And 51 patient with proximal tear, satisfaction was in 75%, and 71% of patients returned to sport. So very big dramatic difference between the type of tear you repair. So the people who had mid-substance tear had much higher failure rate comparing to those patients who had a proximal tear. And even in 1993, when the repair was done openly, not arthroscopic, I'm talking about open ACL repair, the results was a dramatic difference. So what were the factors that made ACL reconstruction more popular and ACL repair less popular? During the early 80s and 90s, Google was not that much popularized among surgeons all around the world, and research and looking at the literature was not easy. The language barrier was much of a challenge. Majority of the publication on ACL repair was not in English language. Arthroscopic company invested a lot of money on the equipment to help surgeon do reconstruction, not repair. And obviously the other biggest factor was repair was done openly, so that was something not considered a gold standard in 1990s, and majority of the surgeons were more interested in doing arthroscopic work, which was available in the market in the form of screws, arthroscopic equipment, and reamers to perform a successful arthroscopic surgery rather than an open ACL repair. So first factor which we all need to understand, does ACL has potential to heal? So we are planning now to shift from reconstruction to doing some patients repair, not all of them, some of them. But the question is that does ACL has the potential to heal? Can we stick the ACL back onto the footprint and it will heal? So the healing potential of ACL tissue has been studied by Bertinard, Sonny, Ricotet, and Murray, and they have published their work. I think this is a real problem. I can't, they have to give me something different because, so 26 ACL tissue and 23 ACL tissue, they harvested the sample and sent it to the lab to look at the healing potential, and they looked at the result that the damage area of ACL when it ruptures has very well vascularized tissue, numerous fibroblast and myofibroblast, and mechanoreceptor. This means that when the ACL ruptures, the area where the injury happens has got a lot of vascularity. So if you stick it back or if you preserve the stump, the mechanoreceptor and vascularity is maintained. We have done similar study in our unit in AO Hospital, in which we looked at evaluation of healing capacity of anterior cruciate ligament tissue. We took the samples from the damaged end of ACL. We also took the samples from the base of the ACL, and we also took the sample from a non-ruptured ACL. And we sent it for hemotoxin and eosin staining. Our histopathologist helped us. There was 20 damaged tissue, 40 samples, Normal ACL tissue, 12 samples. And we did CD34 immunohistochemical staining because it expresses actually micro vessels and fibrocytes. So when we looked at that in detail, we were amazed to see that the ruptured end of ACL has numerous fibroblasts, significant higher value of synovial angiogenesis, ligament angiogenesis, and fibrocytes at the ruptured end of ACL. But this is the most exciting part, that the remnant angiogenic potential significantly decreases 12 months after injury. So the sample which we took for the lab showed that if you want to intervene, it should be quick. So within 6 weeks, 3 months to maximum 6 months, because the longer you delay, the vascularity is compromised and the tissue will not be a viable tissue, which is shown in our study. We published our work in the Knee Journal and also presented in different conferences. So now, what is going on nowadays and what's the trend with regards to ACL tear and what is repair option available? So let's look at a couple of the options. So we have options of suture anchor repair. Recent publication, BEAR, which is called Bridge Enhanced ACL Repair. We have internal bracing system. And we have dynamic intra-ligament stabilization. So these are the different types of repair method available in the market. And as you can see, there is not a huge amount of publication at this stage in the literature to say that we are doing a huge amount of repair, even though it's becoming a very popular and a very hot topic. So my inspiration came from Gregor de Phillis from Hospital of Specialist Surgery, a colleague of mine who actually published the most number of work on primary ACL repair. He used suture anchor for the proximal tear with, now he adds internal brace. If you look at the video, you use scorpion or whatever method to hold the ACL tissue from the base, run the Bunnell stitch up to the proximal part, and you can use 2 anchors. He uses swivel lock for the 2 bundles to attach onto the footprint. His results have been shown to be very promising, 5 years to 7 years follow-up, in which he has actually recommended that repair should be done in someone over 25 years of age, non-professional, medium demand patient rather than professional sports player. Bridge Enhanced ACL repair, published by Murray recently, have shown almost equal result to ACL reconstruction. The trial started in 2016, only 10 patients were recruited. 2019, they published their results of 2 years follow-up, and they have shown that the bridge enhanced ACL repair with the help of this scaffold actually gives similar result to reconstruction at 2 years follow-up. Internal bracing, which was invented or popularized by Gordon McKay from Scotland, acts as a seatbelt mechanism. You pass the fiber tape through the cortex, and with the help of this method, you can stick the ACL back onto its position. The failure rate has been shown to be 4%. In his series of 68 patient 1 year follow-up, there was only 1 failure. So this is the most commonest procedure used at this stage for ACL repair. Dynamic intra-ligament stabilization has been quite commonly used in Europe, especially in Sweden. It's a very interesting fact that Egli and Henley has published this work, and over 300 patients has been operated with this procedure, the largest number ever. But the failure rate has been shown to be 10 to 30%, which is quite high. You use the dynamic ligament stabilization to fix on the femur and onto the tibia, but the issue with this method is that 6 months down the line, you have to remove the dynamic screw from the tibia in order for the patient to go back to its activity. So potentially 2 operations. But despite that fact, a couple of the German surgeons are still using it. So I was concerned in Pakistan, what should I do? Because of the cost problem in Pakistan, just like Tunisia, I wanted to use a method which is simple, easy. So the drilling the tunnel, removal of hardware, ease of revision, and cost. So I decided to use a single anchor technique, type 1 and type 2 tier, no tunnels, easy to revise, and that was my approach. So I'll take you through a couple of the case and you will see the step-by-step method. Type 1 and type 2, proximal tear is my choice, age over 25, clinical examination plus MRI scan, arthroscopic examination to proceed, good tissue quality to hold the suture, and grade 2 to 3 cartilage damage and multi-ligament were excluded. But now in multi-ligament, if I feel ACL repair is possible, I do them. So in ACL and PCL, if I can repair the ACL, I will repair the ACL and I will do the reconstruction of PCL. Obviously now I'm doing it for the last few years. If you see, this is 140 kg man who was low demand. He has an ACL partial tear, not off the footprint. He had instability, so I did his repair. It's now coming up to 2.5 years. He's quite happy. He's not a runner. He just wanted to go back to work and his business. So we managed to put the footprint back onto its position. So if you look now, anchor has been deployed. The ACL tissue is reasonably stable. I'll show you the whole video now. So let's start with the surgical video. I hope it switches on. It is a step-by-step technique. So I look at the MRI scan, and in this MRI scan, this is a fresh injury, and you can see the tear is proximal. It's not off the wall. It will be called Sherman type 2. So we will go inside with the help of keyhole surgery, 3-portal technique, anteromedial, anterolateral, and also the center of the patella. You make your incision. It's very simple and very easy to just make the incision. Make sure you use shaver. Have a look at the tissue. The vascularity is well maintained. It's not off the wall. Simple instrumentation, suture cutter, suture passer, drill bit, guide, and then suture manipulator, and I only need 2 sutures. With the help of the first suture, you go from the central port, you make a locking stitch somewhere between the mid and the tibial part. Then you use the second suture to do the running stitch. You make sure that you clear the tissue and you use the probe to move the running stitch more proximal to the footprint. The more proximal you are to the footprint, the easy the anchor will be deployed and the tissue will be held in a very nice position. So you keep on doing, you keep on putting this running stitch more to the proximal part. With the help of this drill guide, exactly at the 90-degree, you make your first anchor. I use relax anchor, which is available, which is called striker relax anchor. It is able to deploy 2 sides of the suture, and it has also got tensioning effect. You pass the one end of the suture from one side, you pass the other 2 ends of the suture from the other side, your assistant holds it, you keep the tension in place so that the suture is not very lax, and you gently insert the anchor by keeping the tension onto the suture. So you keep on going onto the second laser line. And once you've done that, you remove the wide sutures and you do the tension effect. When you twist, the remaining laxity is reduced and you remove the anchor, as you can see on the video. The knee is nice and stable. Once you have a feel of that, you feel with the probe, the loose tissue is tight. You cut the sutures, you take the patient knee from range of movement to make sure there is no laxity. You do some microfracture for pleuropotential cell to migrate there. And with the 3-portal technique, the ACL repair has been performed. 24 months post-op, MRI scan. If you look, there is a small metallic thing on it. The ACL tissue is well aligned. The graft of the tissue is very stable. The range of movement is good. 54 patients done so far since 2019, 3 failures, 2 revisions. We have done their scoring system and 12 months MRI scan. Obviously, we are still going through an evolutionary phase of understanding ACL repair. I do not perform ACL repair in every patient. I do big numbers of ACL reconstruction, so my repair is only 10 to 15% comparison to reconstruction, which I still do 90 to 85%. But I feel there is an important role of ACL. You do not only lead yourself to repair of the proximal tear, you can also do tibial avulsion fixation with the same method using any anchor technique or pull down technique with the ABS button, whatever you want to do. Couple of the results, if you can see, patients are very happy. They don't have any pain. The rehab is much faster. The patient do not feel, interestingly, any pain post-op, which is quite amazing because you don't take hamstring tendon, you don't drill the tunnel, you don't put the screw. So in conclusion, preserve the nature, save the ACL, and as by Darwin, we are going through the evolutionary phase of new technologies. And what's the true definition of evolution? It is progression without planning. Thank you very much.
Thank you, Omar. It was an excellent lecture. And I would ask you, what is your postoperative protocol for this type of repair?
So thanks very much. So the post-op rehab is almost the same like I do for my reconstruction. I don't put them in a brace now. I let them allow weight bear as pain allows. Majority of the patient are able to fully weight bear in a week's time. Their range of movement is allowed straight away around 0 to 30 in the first day and then progress to 0 to 90 in the first 7 days. And they can do quad strengthening exercise straight away. So exactly the same protocol like we do for ACL reconstruction. I don't brace them, I let them weight bear.
Thank you for your good presentations. I have questions. In what degree of range of motion you suturing the tendon?
So
the ACL graft?
I would fix the anchor in the same position like you are doing the drilling of the femoral side between 90 to 100 degree. I keep the knee in a flex position and then I insert the anchor.
Thank you.
Yes.
Thank you for this excellent presentation. The question is, what's your cutoff time from trauma to OT? And the second question, why over 25 years? Why not younger?
Okay.
Thank you.
So, very good question. So the first question, which has been shown in the evidence published by our series and by Bertinard Sonnery Cotet, which did not look at the time lapse. So we have seen in our study that the patient who have ACL tear, 6 months to 12 months, the migration of fibrocyte and vascularity suddenly decreased. So ideally, the quicker you go, the better. So my cutoff choice is maximum 6 months. After 6 months, it's very, very unlikely I will go for repair. So the quicker you go, the better. So that's the answer to the first question because it has been shown not only in our study, but other published work. With regards to over 25, because the literature has shown by the study done by Gregor de Felice, which has done the largest number of ACL repair, that the failure rate is much higher in younger population because of their activities, the healing potential, even though is very good, but the way they play sports, the risk of re-rupture is much higher. So their recommendation was that patients who were over 25 and especially over 30, their re-rupture rate was much lower comparing to those who were under 25 and professional players. So I would not do in a professional footballer, in a professional cricketer. I would do ACL repair in someone who comes and he says, I'm a banker, I play golf, I occasionally play football, and that is something I do it for fitness. Yes, you can repair them.
Thank you, Dr. Omar, for the presentation. Just asking about the way you suture the nearby, actually the damage itself. It seems that the suture, the way you're doing it, it's almost sort of sometimes squeezing actually the tissues, and this might actually affect the vascularity then after at the damaged site. Thank you.
What we are doing actually, there are two different type of surgeons who are doing different type of repair methods. So one repair method is that you use an internal brace and you just passed, and they also do the same suturing technique. With regards to that, the vascularity is compromised because the size of the suture is very thin. It's not a very thick suture which we used, which can be anything by Arthrex or Stryker or whatever company you use. So all these sutures actually are non-absorbable one. And with the anchor, which is the peak anchor, you are only actually, the main purpose of doing repair is to, in my clinical scenarios are, I do not repair the one who are off the wall. I will only repair the one which is partial tear. So I know that 50% of the footprint is still attached. So the vascularity is still there. I'm only tightening up the loose tissue, exactly the same like a rotator cuff tear. The whole rotator cuff is attached and we have a crescent type tear. I'm bringing it back into the footprint. So I'm actually tightening up a loose ligament. Its vascularity is already there. And when you saw 24 months MRI scan, that was not the case. The ligamentization after 24 months was exactly the same. There was no high signal intensity. The length of the ACL tissue was well preserved. And it's not only in one series, in many series it has been shown that by this suturing technique is much better than any other.
Then it's a fixation on an internal brace. You have an internal brace, definitely.
So there are different methods. You can use internal brace technique and you can use suture anchor technique. Okay. So my choice in Pakistan especially was to use a single anchor because of the cost. Okay. So if you go for internal brace, you have to put a tape, then you have to put a swivel lock. So it adds quite a lot of value. With the single anchor, the other benefit, Sufyan, is that it's very easy to revise. The thickness and the diameter of the anchor is 4.5. You can remove it and drill the tunnel and do the reconstruction. With the swivel lock, if you are using 4.5, it is almost 9 millimeter. So you are in a trouble if you go for revision. With this single anchor, the revision is easy.
Okay, another question.
Thank you for your presentation. So regarding this healing potential, I want to know what do you think, what is your experience in ACL reconstruction with remnant preservation?
Yeah, there have been many published work now that if you preserve the remnant, it improves vascularity, it improves the proprioceptive fibers, and I would try my level best to preserve ACL stump as much as I can.
Last question.
Thank you for this presentation. Concerning this repair procedure, I want to ask the failure post this repair procedure is occurring on the tibial side, the remnant tibial side ACL, or in the repair side? It is due to healing or due to re-rupture in the proximal side?
So your question, if I'm not wrong, is you're saying which side has got much higher failure rate? Yes. So interestingly, in my experience and literature has shown that the tibial sided avulsion has much higher failure rate in patients over 18 to 20 years of age. So if I have someone with the tibial spine avulsion, 3 months old, 25 years, I will do reconstruction. I don't fix their ACL avulsion. If he comes within 3 weeks, 6 weeks, fresh injury, I will do the repair. Otherwise, I would never repair or fix ACL avulsion in somebody over 6 months, especially if the age is 20 to 25, because the failure rate is much higher.
Thank you very much, Omer. Thank you very much. We'll go back to the videos with live with Dr. Go for ankle arthroscopy. Hi, Go.
Hello, good evening. Good morning to all of you in Tunisia, and thank you very much for this invitation, Sufyan, and to the Tunisian Orthopedic Association for this invitation. It's a true honor.
Thank you very much for being here on Sunday.
Thank you for the invitation. This is quite a difficult task, talking about foot and ankle arthroscopy and endoscopy in 10 minutes. So I'm going to try and make this an interactive clinical video session and try and outline what is the latest current landscape in the foot and ankle arthroscopy and endoscopy world. So the outline of my talk, I've got no financial disclosures directly related to this presentation. And I'll talk a little bit about foot and ankle arthroscopy. And then I talk a little bit about what we are currently doing in the world of foot and ankle endoscopy. And then finally, what my current practice landscape is and how these new techniques have impacted on the choice and nature of my practice. And then I'll finally try and summarize with some take-home points. So we've all seen this and are very familiar with the conventional ankle arthroscopy, anterior ankle arthroscopies, and I typically use a 4 millimeter scope, 30 degrees, with a 3.5 oscillating shaver. And this is quite standard. Most people would use this, sometimes a smaller scope. This is how I typically position my patient with a sandbag underneath the ipsilateral bum to make sure the toes are pointing up to the ceiling. And the left contralateral ankle is adequately padded. Surface markings are important. Usually for the purpose of fellows and residents, always mark out the medial malleolus in an anterior ankle scope and also the tibialis anterior tendon to make sure that the landmarks are surfacely pointed out. And then this is the conventional instrumentation position. I use my belly to actually aid with ankle dorsiflexion. And the insertion site for the portal is just medial to the tibialis anterior tendon at the level of the ankle joint. So once I have actually stuck the scope into the ankle, it actually becomes a lot easier to visualize and see things. And of course, the indications are very variable. This is an example of a video with scarring inside the ankle. And this is the first visualization that I see when I put the camera inside in a scarred anterior ankle chamber. And then once it has been debrided, you can see that the ankle joint is a lot clearer. And this can be done with a combination of a 3.5 shaver and sometimes even something a little bit smaller so that you can visualize the ankle joint. Chilectomies are also done very commonly in the anterior setting. This is a video illustrating an anterior lip in the front of the tibia and me moving the talus in the same time. And once that is done, and this has been more prominent, this is an osteotome that is coming in from the contralateral portal to actually excise that prominent osteophyte. And of course, once that's done, you then have a raw surface like this video, and that can be smoothened out with an oscillating shaver. So anterior ankle chilectomy is very common. Sometimes the impinging lesion is like we do see in the knee as well, a kissing lesion. Sorry, I've just gone past that video. A kissing lesion. So in a kissing lesion setting, the osteophytes are a lot more prominent. This is again an anterior ankle scope view showing the prominence in the front of the tibia, but also large osteophytes and loose bodies just over the talar neck region. And so you can imagine in the setting of anterior ankle bony impingement, this can be a real problem. Again, a very useful indication for anterior ankle arthroscopy. Arthroscopic ankle fusions are another indication for anterior ankle arthroscopy. In my practice, I use the 3.5 and even the 4.5 acromionizer to prepare the joint, remove the debriding cartilage to get a nice clear space, and then percutaneously insert screws that are usually either 5.5 or 6 millimeters. More recently, I even do my triple arthrodesis with a scope, fashioning portals, and this is a visualization of the talonavicular joint, and you can do the same and look at the back of the subtalar joint as well through a subtalar portal and curate it out so you get nice raw bony surfaces, multiple small punctuate lesions, and fashion the portals through the back of the fibula for conventional subtalar arthroscopy, which will then enable you to prepare the hindfoot joints. Of course, just like anterior ankle arthroscopy is common, posterior ankle arthroscopy has also got its role and its value. The important thing with posterior ankle arthroscopy is point number 3, to respect and use the FHL as a consistent landmark. So in the setting of posterior ankle arthroscopy, again, this is a video looking at the back of the ankle. Again, you can see the FHL tendon there as I'm moving the FHL tendon, always using that as a landmark. And in this particular pathology, there's an osteochondral lesion at the back of the talus at the 2 o'clock position. I'm using a shaver to try and debride and clear that out until nice stable margins are achieved. And again, once that is achieved, then I use a scaffold, a chondral scaffold. This is the entire chondral defect. You can see from the front to the back where the microfracture has already been performed, and then resurface it with something that acts as a scaffold like chondroglide or Hyalofast or whatever is available in local practice. Of course, in the setting of fractures, arthroscopy is also very useful. This is a patient with a talar neck fracture that has then been fixed. And we've got good evidence in the literature now to support the wealth of evidence to show that cartilage lesions are very common in the setting of ankle fractures. And so in this setting, once the fracture has been fixed with conventional screws, it's actually very useful to put a camera into the subtalar joint. Again, a smaller scope, this time a 2.4 millimeter scope with a 2.7 shaver, and you can see the fracture site and also the chondral disruption which results. This is me visualizing the posterior facet of the subtalar joint right down into the gutters. And if there's any obvious disruption in the cartilage surface, it'll be very obvious. Of course, in the setting of in the setting of syndesmosis, we all recognize that, visualizing the syndesmosis in a fluoroscopy with the hook test is often not very easy. But in the setting of an ankle arthroscopy, putting a probe into the fibula incisura, this is the fibula on the lateral side back of the screen, this is the tibia on the top, and if you put a probe in, a conventional 0.5 mm probe, and it's not able to fall into the gutter, then the drive-through sign is negative. And if it's negative, then we can say really quite confidently that there is no rotational instability and neither is there any medial lateral instability. And this is probably the gold standard way of confirming intraoperatively if there is a syndesmotic instability that is present. The role of arthroscopy in that is very useful. Now, moving away from the joint, what about tendoscopies and endoscopies in foot and ankle? What currently are we doing? And is this just purely a C-suite perspective? And when was this first started? For again, this was described almost over 2 decades ago, but a lot of the credit goes to Nick Van Dyke, published a report on tendon sheath endoscopy of the peroneal tendon at the end of the last century. Now, what Nick Van Dyke did very well, and again, the question really here is this very much a current practice trend, or indeed is it just a magical show? So in the current state in 2022, it's certainly the evidence in the literature, but also in my personal opinion, that arthrotendoscopies or endoscopies have both a diagnostic value as a therapeutic value. Of course, in terms of cartilage lesions and impingement lesions, like we've talked about, the evidence and the practice is very clear. But in the setting of peroneal tendons or gastrocnemius tightness, or even Achilles pathologies and tibialis posterior tendon pathologies, exactly how useful is tendoscopies? And so this particular study, a systematic review by Nick Van Dyke, they looked at multiple different databases and yielded 328 articles, selected only 57, and afforded a grade of evidence to each one of these papers. And this is what it showed. So if you look at all the different anatomical sets on the left side of the screen, from the Achilles all the way down to AHL and EDL, and they looked at the different papers and their level of evidence. And sure enough, you would agree that most of the papers that have been published focus around the Achilles, the peroneal, and the FHL, and fairly enough, the evidence is between a level 4 and a level 5, with a relatively small number of retrospective analysis. And so they concluded, in all fairness, that the evidence is currently weak, but indeed most of the papers and evidence would circulate around the Achilles, FHL, and the peroneals. And most studies were done by really quite highly experienced foot and ankle surgeons. And so what is my view of this technique, and what do I do in my practice? Now, what is my rationale of doing tendoscopies? Well, I think there's a superior cosmetic result, obviously, in comparison to open procedures. Theoretically, there's going to be a lesser risk of complications and indeed a much shorter time of recovery, and this has been proven. It is an excellent diagnostic tool, and sometimes even with a static investigation like an MRI, we don't pick up small split tears or vincular tears, which is something we can pick up with the tendoscopy, which is a more dynamic assessment. And just because there isn't a strong recommendation in the literature at the moment, I do feel that it's just a matter of time before bigger and better studies become available in favor of tendoscopies. And so when do these techniques feature in my practice? Well, in the setting of tight gastrocnemiae, I certainly do endoscopic gastrocnemius recessions. And these are largely in the setting of forefoot reconstructions, diabetic foot ulcers that are not healing, and even in the setting of flat foot reconstruction. Well, it's a keyhole procedure at the level of the mid-calf, and this is where I do them. And of course, there is an equal number of papers and scientific evidence to support the role of a medial head release just at the level of the knee. I position the patient in a lateral position with a bolster beneath the leg, and I sit on the same side as the patient, looking at the screen on the opposite side. And this is roughly how the technique is employed. A camera goes into the mid-calf level, and then the screen is sitting at the opposite. You get to see the entire gastroc aponeurosis, and then a blade comes up just there at the tip of the screen, and you just resect the aponeurosis from the medial to the lateral end. And that's an endoscopic gastrocnemius recession. What about the peroneal tendons? Well, predominantly, the main indication is going to be pain over the back of the fibula, pain in the subfibular margin. And we published this in about 2.5 years ago, and we looked at the last 43 cases and followed them up. And these are the common indications for doing a peroneal tendoscopy. Well, why do them? Again, conventionally, you would have a large open incision like this to examine the peroneal tendons and both the PL and the PB, as well as the superior peroneal retinaculum, the groove, and look for any other pathologies like the peroneus quartus, or indeed any other bony abnormalities. But with the 2.7 scope, 330 degrees, and a smaller shaver positioned supine, you get to do that through a much, much smaller incision, like the picture shows at the bottom. And by fashioning the portals correctly, insufflating the peroneal tendon sheath, and sticking a needle into the correct position, you really get an excellent view of both the peroneus longus and the peroneus brevis. So this is a video presentation of a scope I did just over 3 weeks ago. Oops, sorry. And I'm sure you'd agree that you really get to see the entire girth, volume, and consistency of both the tendons, peroneus longus as well as peroneus brevis. Any striations or fibrillations within the sheath, any tears within the tendon, abnormal connections like vinculi that may cause the tendons to subluxate intra-sheath or even subluxate out of the tendon becomes very obvious. As you draw the scope out, just as it skirts down beneath the tip of the fibula, you also get to see any tears within the tendon as it skirts in through its retromalleolar groove. So it's really a very, very rewarding procedure, and you get to pick up pathologies that the MRI may have mixed, and it helps you guide exactly where you're going to do your mini incision if you choose to repair it, or indeed even leave it without having to do anything. There are now a lot of techniques that enable us to do lateral ligament reconstructions through a mini approach, arthrobostrum, which is a keyhole, and this is a visualization of the calcaneofibular ligament. And again, the same technique is employed. And again, this is a peroneal tendoscopy where a shaver has been put in, and there's a lot of scarring in the tendon sheath. But by putting in the small shaver and visualizing it direct, you get to clear up the entire tendon sheath and then inject the biological if you have to, but move the tendons to make sure that the assessment is very dynamic and there's no sheath subluxation or indeed any tears at the same time. So very rewarding and a high yield procedure. Of course, the same thing can be employed in the Achilles as well. This is largely for bursitis, Haglund bumpectomies, and even sometimes in the setting of an Achilles rupture. So let me explain. This patient is positioned in a prone position, as described by Nick Van Dyke. Again, I use a small scope and a small shaver, full radius. And in the setting of an Achilles tendoscopy, you want to position in an anterolateral, distal, and proximomedial position. And this is what it looks like. And again, in the setting of an Achilles rupture, once the repair or before a percutaneous repair is done, and you want to visualize the nature of the tear and the actual architecture or geometry of the tear, if there's a spaghetti strap appearance or if it's a clean transverse rupture, a quick scope before the incision is made can be very useful. In the setting of an endoscopic calcaneoplasty, like a Haglund's syndrome, again, you get to visualize the Haglund bump using a fluoroscopy image and do blunt dissection to put in your scope at the correct position. And then, of course, insert your small scopes the same side, put an osteotome at the same position, and you get to shave off the Haglund bump down to a flatter position. And finally, you take a fluoroscopy image and you get to knock off the bump as much as you want and even finish it off with a burr if you have to, which is what I tend to do these days. Finally, coming on to an end, in the setting of a tibialis posterior tendon as well, you get very clear visualizations of the entire tendon, and this is very common in patients with tibialis posterior tenosynovitis or even adult acquired flat foot deformity, where they may have split tears behind the medial malleolus, or even as it comes down. But this kind of position where you get to move the foot and examine the entire course of the tendon is very, very useful. FHL tendons are also amenable to tendoscopies. This is a patient of mine with pain at the plantar surface who didn't do well with first metatarsal orthotic and a biologic injection, and 4 months later underwent a FHL tendoscopy. And this is a video of that visualization. Again, you get to move the tendon and see the entire course of the FHL tendon just to make sure that it's not stuck or indeed even torn at a fixed position. Incisions at this side are not very forgiving, and so it's always useful and better to be able to visualize the actual site of the pathology before making the incision. And it's true, and I agree, that just because we have a hammer, it doesn't mean the world has to be the nail. And this was said by a very famous person just over 7 years ago. But I think in conclusion, I think the remit of foot and ankle arthroscopy has evolved considerably from being a diagnostic tool to a really versatile therapeutic adjunct. We use it in the setting of syndesmotic assessments and fractures, but also in the setting of various pathologies from osteochondral defects to ankle impingement, bony and soft tissues, stida processes that are prominent, loose bodies, etc. But soft tissue, arthroendoscopic techniques and tendoscopies has really become the newer adjunct, both as a diagnostic as a therapeutic maneuver. And the commonest sites at the moment seem to be the peroneal, the Achilles, and also the gastrocnemius. And there are obvious advantages with tendoscopies, but the evidence is still evolving. And I think in the next decade, we will see a lot more strong evidence coming out to support the role of tendoscopies and arthroendoscopic techniques in foot and ankle. And I look forward to that. And on that note, again, thank the Tunisian Orthopedic Association for this invitation. And also I'm look forward to seeing you all at the SOTCOT Congress in September. Thank you.
Thank you very much, Joe. Thanks again for being here on Sunday. It is Sunday afternoon now in Singapore.
Yes.
I will see if there are any questions in the floor. Unless I have some question, I have some concern about the Achilles tendinitis with calcified Achilles tendinitis. It's not about Haglund, but it's the calcification of the distal Achilles tendon and the fear to have fragilized the tendon when you are doing an arthroscopy. What is your attitude within these cases?
I agree. I think that's a great question. So I think the indication for an endoscopic calcaneoplasty or endoscopic Haglund bumpectomy is very, very narrow. So if a patient does not have any posterior calcaneal tuberosity pain, no posterior calcaneal spurs, and there's no significant evidence of pain at the back of the Achilles footprint, then I think they do well with an endoscopic technique. But if they have a large calcific deposit, like you said, an Achilles footprint that is very inflamed and very calcified, then I think they do better with a mini open surgery rather than an endoscopic technique.
Okay. Do you combine? I see that you have you do the arthrodesis of the rear foot when you triple arthrodesis. In tibial articulation, I agree that we need arthroscopy, but with the new techniques, with the percutaneous arthrodesis, only with the burr in subtalar arthrodesis, I'm not if you combine these two techniques, only remain only arthroscopic.
Yeah, I think that's also a very good question. So I went obviously from doing them open to mini open to hybrid to now all arthroscopy. But in all fairness, I think the patients who benefit the most with all arthroscopy techniques for ankle and subtalar are usually the ones with poor wound healing complications, like the diabetics. Because they don't tolerate open incisions very well, and if the access is good enough with an ankle arthroscopy and a subtalar arthroscopy, then I think the biology is better and the fusion rates are better as well.
Thanks again for being with us. Hope to see you soon in Kuala Lumpur and maybe see you in person in Tunisia next time for our next meeting. Thanks again.
Thank you very much.
Thank you very much.
You.
We will go forward regarding the time to the conference of Dr. Murad Gharairi from Dubai. Meanwhile, I will give you 2 minutes to someone, because we will skip the coffee break. Someone who wants to take a coffee or something like that, they come back to the room within 2 to 3 minutes if you wanted to take a coffee.